Thank you so much for the gracious introduction. And it is such a delight. I'm so pleased to be with you today. I was hoping I could be physically with you and come to Bandung again. So I've been there. It's a beautiful place. So hopefully in the future, we will have the opportunity to do that. And now we also take the opportunity to be able to come together virtually and discuss the complex relationship between infections and SLE, particularly as they would occur in our part of the world. And again, thank you for this gracious invitation to join you this morning. So my outline for this talk is infectious agents as they would have a part in the development of lupus. And we'll delve a bit more into pathomechanisms and focus on viruses, particularly Epstein-Barr virus. And then we go into the spectrum of infections in our patients with lupus, move on into the studies on the susceptibility or risk factors, as well as maybe some predictive parameters that have come up recently. And a hot topic would always be the relationship between lupus and COVID-19. The course of SLE goes from a preclinical stage wherein the patient will not have symptoms, but you have predisposing factors. And the predisposing factors can include a host of insults like environmental and hormonal insults. Genetics, of course, will always be there. And I look forward to Katsuya's talk on this. Diet, likewise, and they have talked about the role of microbiome in patients with autoimmune diseases, including lupus. And then you go into a benign autoimmunity, and then more into that in the immune complex production, as well as autoantibody and cytokine production, and pathogenic autoimmunity, wherein you now express this because of your organ involvement with clinical features. And finally, you meet now into what ACR and Euler have been preparing for us in terms of classifying, not diagnosing, but classifying patients with SLE. And you can see there that as we go through this, you have the initial triggers, and then little by little, the players in the immunopathogenesis of lupus come in with more of this autoantibody production, and as well as the involvement now of more of these cells, immune cells, that play a pathogenic role in the eventual expression of SLE as we see them in the clinics. So this is a simple diagram wherein in any situation of an autoimmune disease, you actually go through this process. So the first, especially in the role of infectious agents in the development of autoimmunity. So you do have, of course, the natural response to any infection, regardless of what kind of infection, including viruses, including parasites, including bacteria, would go into a stimulation of your innate as well as adaptive immunity. And then something goes wrong somewhere because of the microbial persistence, molecular mimicry, and co-stimulation. Then that leads on into, plus now your involvement or the contribution of susceptibility genes as well as environment that moves on into the recognition now of your own self as maybe cross-antigenic with this initial stimulating or triggering factors or antigens, external antigens. Then they become recognized as self. You develop now your immune complexes. And then you have autoantibodies, and autoantibodies play an important role in the expression, in the organ involvement, in the inflammation that we see in our patients with lupus. So this is a more recent diagram in the potential mechanisms of infectious agents in lupus pathogenesis, outlining the mechanisms as in any immune reaction to any infectious agent. So they can come in because of molecular mimicry, epitope spreading, super antigen production, which bypasses the usual presentation of antigen to a T cell and just stimulates the T cell, persistent viral infections in some cases. You can have bystander activation, you can have altered apoptosis, defective clearance, especially when you have ultraviolet rays that can increase apoptotic cells and expression of these antigenic results or products of apoptosis. and present them to the system. And then your body now has a reaction or mounts a reaction to these autoantigens, leading on into immune complexes, activation of your complement, and eventual inflammation in the different organs, as well as many of these genetic factors, which are now just coming up. And I would look forward to Katsuya's talk on this likewise. So infections really play a role, regardless of how you look at it. There have been a lot of studies that put in and implicated infections in the preclinical stage. So they trigger. So you can have a genetic susceptibility, but you may not express the disease, but something goes wrong somewhere because of the environment. And part of that environment is really made up of infectious agents. And in these infectious agents, they go now from preclinical autoimmune process to clinical, maybe subclinical, wherein you can only have a positive anti-nuclear antibody, anti-double-stranded DNA. And this is what we call as a serologically active but clinically quiescent disease. And then you move on into more clinical lupus and an actual autoimmune disorder, wherein they get now classified as SLE, with all the consequences here, like antiphospholipid syndrome and many of these that overlap with each other in terms of presentation, including vasculitis and so on and so forth. And of course, we will have to put in also the role of medications in the expression likewise of the disease. Now, a central role there, as I was mentioning, is EBV. And I'd like to take this opportunity to discuss and focus more on the role of Epstein-Barr virus in lupus. There is a lot of evidence, and there is a lot of more evidence coming up from the cohorts in Oklahoma. That's from the Oklahoma Research Medical Foundation, and Carolina, USA, Taiwan, Mexico, Japan, and then Philippines, which I will be showing you on our own collaborative studies on establishing the role of Epstein-Barr virus in lupus. And we have the evidence that anti-EBNA, which is your nuclear antigen in Epstein-Barr virus, occurs even before human lupus autoimmunity, and anti-VCA antibodies even continue to rise until the diagnosis and the classification of lupus. And then we have immunization of animals. Actually, if you inject EBNA or nuclear antigens of Epstein-Barr virus, these cross-reactive regions can lead to lupus-like autoimmunity. And in the pathogenesis of this, sequence homologies exist between lupus autoantigens and some Epstein-Barr virus proteins like EBNA1 and 2. And then we have Epstein-Barr virus also promotes proliferation of B cells after infection, leading to prolonged, persistent antigenic challenge. And thereafter, the autoimmune process just continues to move on to express itself as the disease. And Epstein-Barr virus infected B cells can also by themselves become a continuous source of autoantibodies. And here is what I'd like to share with you. This was brought about by an initial process wherein Professor Weissman invited the University of Santo Tomas and said, okay, can you collect now serum, or can you collect the specimens from your patients with lupus, first-degree relatives, as well as healthy controls. And these are all Filipinos. And you can see the name there. At that time, Dr. Laniati was our very prolific research fellow then at the University of Santo Tomas. So we were all in this together. And then this they identified samples went on from the original index study, which looked at autoantibodies among patients with lupus with their first-degree relatives. And Judith James, who was from Oklahoma Research Medical Foundation, actually suggested and said, okay, Sandra, let's move on and investigate this. And at that time, Dr. Vista was also doing further studies there and went on into collaborating here. And here are the findings. So here you can see here that in looking at the various antigens and autoantibodies that they developed in the laboratory of your Epstein-Barr virus, you can easily see here that there was an increased seroprevalence of common herpes viruses in Filipino patients in our cohort, in Filipino patients with lupus. whether it be the VCA, CMV, or HSV1 or HSV2. So the black ones are the control, and the SLE patients are in white. The gray one are in the first degree relatives, and you can see that they also share, perhaps by some form of genetics, they also share many of these characteristics with the index lupus patients. And they also, our cohort, our Filipino patients with lupus also carry even a greater antiviral antibody concentrations than the unaffected relatives. These are first degree relatives or even healthy controls. And you can see that there. So if you can look at the anti-EBV, CMV, HSV, and HSV2 are significantly higher among our SLE patients. So this was really compelling evidence. And if you put that and also translate that into looking, what about their autoantibodies? As a matter of fact, the higher the seropositivity in lupus, Filipino lupus patients, this was associated with increased levels of autoantibody positivity, as you would see here. So here you have the seropositivity of these patients for EBV early antigen. And if you look at the autoantibodies, these were higher in those who were positive for the EBV early antigen or EBV-EA. So that was, and of course, we started off with saying, what are the possible mechanisms? And a simple mechanism would still be a cross reaction of EBNA1 with your Smith and Rowe antigens, producing now your common autoantibodies that you act under this. So the conclusion there of that particular study with our cohort among Filipinos was that Filipino patients with lupus have elevated prevalence and concentrations of antibodies against EBV, CMV, HSV antigens, along with altered nuclear antigens of Epstein-Barr virus specificities. And Epstein-Barr virus reactivation is more common among Filipino patients with lupus compared with healthy Filipinos and may contribute to SLE pathogenesis in this population. So this is really compelling evidence of a virus, particularly the role of Epstein-Barr virus. And we know it is not just in SLE, but EBV is a virus that has been implicated in lupus, in rheumatoid arthritis, and other autoimmune diseases, as well as even some tumors or neoplasms. So infections in lupus, it is a headache. It is a headache for lupologists. It's a leading cause of morbidity and mortality in lupus. It's a big challenge when you go to the bedside and determine, is this infection, is this lupus flare? And that is a continuing challenge in any patient, in any lupus patient who comes with fever, because you have higher morbidity and mortality if it is indeed due to infection. SLE patients are susceptible not only to opportunistic infections, but likewise to common infections. Increased susceptibility is due to inherent immune abnormalities that you find in lupus, but more so the immunosuppressive therapies that we use, particularly your glucocorticoids. And I'll give you bits and pieces of what we have been doing in our among our lupus patients. And for example, these are the reasons for hospitalization among Filipino patients with SLE in a total of 596 hospitalizations in 430 patients. The reasons for hospitalization were as expected. Lupus flare is there, especially renal. And then we have the combination of both lupus flare plus infection, and couldn't determine whether it's one versus the other. And that's in 14%. And we even see infections in patients who have inactive lupus. And that was seen and recorded in 40%. So that is hospitalization. What about causes of death? Causes of death is just one of the early studies by Cervera and group and Bernatsky. And they saw that the most frequent causes of death in their lupus patients were active lupus, as we saw in our own cohort, thrombosis, and infections again. So infections are there again. And the most frequent infections were bacterial, sepsis of pulmonary, abdominal, as well as urinary tract. Compared with the general population, lupus patients are significantly more likely to die of an infection, with an infection-specific standardized or SMR ratio, mortality ratio of 5 times more likely than the general population. And among Asians, so that's more in the European population, but even among Asians, the infection was the most common cause, was a common cause aside from lupus flare. So this is infection here, and these are the countries that that were recorded in this particular study, and infection made up a huge part of the cause or of mortality in these patients, and with or without a lupus flare. So indeed, it is a problem. It is a challenge, and the frequency of major infections are fairly consistent. We have more of pneumonias, bacteremia, cellulitis, and skin abscess, and I certainly look forward to the presentation of Lani on TB, especially in our part of the world. So those are some of the more common cases that we see, especially in our part of the world. And these are the causal agents of major infections in lupus: E. coli, Staph aureus, again, TB is there, strep, pneumonia. And in our part of the world, yes, we do see salmonella, and we see disseminated salmonella, as well as Pseudomonas, gram-negative infections of Pseudomonas, and Candida, especially in patients who are immunocompromised with very high dose steroids. So this is one of the more recent ones, and this was by the group from Korea that looked at associated clinical factors for serious infections in patients with SLE. And you can see again, it's fairly consistent that you have a higher number of bacterial infections, upper respiratory tract, especially pneumonias, and urinary tract infection. And this is an interesting study. This was more of a systematic review, recent systematic review and meta-analysis. I'll give you more details on this. You can read more details on this. I'm not a statistician, but I was looking at the relative risk, and I was looking at the p-values, and they looked at several studies on infections as they would occur in SLE versus the general population of healthy controls. And they were able to identify 4 areas wherein they had signals that these were more common among patients with SLE. And if you look here, there are the boxes that show the relative risk and the lines that show the ones that were significant here. So overall, severe infection, pneumonia, and we could see the same thing with tuberculosis, seem to be higher in patients with lupus, and zoster, higher in regardless of the methodology and how you did the systematic review and meta-analysis. And looking at the, well, this is easier to look at in this particular study. They look at now the risk ratio, and one can see at once just by eyeballing here that in these different studies, author and year, in the overall severe infection was definitely more common or higher, much higher in lupus patients compared to healthy controls or the general population. And the same thing here in the analysis of pneumonia, basing it on these various studies, one can see that you definitely have a higher, much higher risk among lupus patients compared to healthy controls or the general population. Same thing. At least 2 studies have borne that out, which were good studies and good quality studies, and they were able to show again herpes zoster as more common among lupus patients than general population. And here is the tuberculosis. So here is tuberculosis, and yes, TB will always be there, especially in our part of the world. So the conclusions and the summary of the systematic review and meta-analysis of infection risk in lupus showed that lupus patients have significantly higher risk of infection compared with the general population and healthy controls. And a pooled risk for infections in lupus showed that overall severe infections were 3-fold higher. Pneumonia was 2.6-fold higher in lupus. Tuberculosis was really high, 6.1-fold higher in lupus patients, and herpes zoster 2.5-fold. So it's an interesting study, and I think I would encourage our collaboration on this and look really into our infections, because I am sure we're not only would be able to reproduce this, but we will be able to reinforce this and substantiate this, maybe with even coming up with even higher numbers on this. Now, this is one of the older analysis of major infections in SLE by Ruiz Irastorza and his group. And they look at what are the factors that contribute to major infection. And easily they were able to identify these factors. Among lupus patients, it was nephritis at study point, previous nephritis, lung disease, previous lung disease. So it was the pneumonia there that of course, respiratory is one of the most common routes of how infections can come in, and leukopenia study point. So those were found by Ruiz Irastorza and his group. And here you have the prednisone. So prednisone, major infection. The use was higher in those with major infection, and the doses were higher in those with major infection. So one can see here that indeed steroids play a role in the higher risk for major infections among patients with SLE. And this has been substantiated in several studies, including tuberculosis. And the associated factors, and here is another study, again, the same study by the Korean group. They looked at mean, aside from associated factors for serious infections in lupus, which is that of serositis and then hematologic involvement, were higher among those with serious infections. But in this red box, again, emphasizing and showing that the higher the glucocorticoid use in these patients in the form of prednisone, more than 7.5 milligrams per day, bestowed a higher risk for serious infections in patients with SLE. So here are some of the other studies. In a large population-based study, glucocorticoid use increased risk of serious infections in lupus, and lupus nephritis ranging from 1.2 to 2.5, and combined use of steroids and cyclophosphamide, and I'll show you a bit more on cyclophosphamide later on, was the strongest risk factor for infectious complications in this particular study. And among pediatric patients, even corticosteroid use at baseline was associated with increased risk of a first infection in lupus patients, with fatal infections in patients, especially if they have nephritis. And the incidence of infectious complications rises with increased daily doses given for longer than 4 weeks. And in one series, there was even a 10 milligram per day increase of prednisone, increased the risk of serious infection 11-fold. So can you imagine what we're doing with our patients when we give our steroids? True, it is dampening, it is addressing the inflammation that we see in our patients with lupus flares, but it's a double-edged sword. So you have to anticipate the risk or side effects of glucocorticoids, particularly in the form of infection. So here is the analysis that was shown, that the similar study of by the Korean group looking at the associated clinical factors. And this is a dose response study of your glucocorticoid use in those with serious infections in their lupus patients. And one can easily see these are actually, if you look at the gray line here, the gray line are the ones that serve as more or less controls here. The gray line are the patients with lupus who were not on steroids or who did not need prednisone. And if you look at the dose response curve, it is a direct relationship that the higher the dose of steroids, the more likely they are, or the higher the risk for serious infections among these patients with lupus. Now, on the other hand, what about antimalarials? In the same study by Ruiz Irastorza, they were able to show that there was a negative relationship. So patients who had serious infections had lower use of antimalarials compared to those who did not have major infections. And that was statistically significant, including not just the frequency of antimalarial use, but it is also the months on antimalarial use. So, and this was substantiated and further reinforced by this study that also showed that hydroxychloroquine, or users of hydroxychloroquine, were less likely, this is the crude risk odds ratio, so less likely to have serious infections than those who were not using hydroxychloroquine. So again, compelling evidence. So what is this about hydroxychloroquine? So among the therapeutic modalities currently used for lupus, only hydroxychloroquine actually is considered immunomodulatory without being immunosuppressive. Now, we can also argue about maybe other drugs now that we have. The biologics as are more targeted therapy, they actually lessen our need for steroids. So that may be something that we need to also keep in mind, that even the biologics and targeted therapies, for the simple reason that they decrease the need for steroids, they will be able to lessen infections, especially serious infections in our patients with lupus. And hydroxychloroquine demonstrates in vitro activity against numerous bacteria, fungi, and viruses. And patients taking hydroxychloroquine are 16 times, it's a whopping 16 times less likely to suffer a major infection. So if there's no contraindication, place all your patients on hydroxychloroquine. Now, this is an interesting study. It's an elaborate analysis of the study. It's a fairly small study. And in these patients, among these patients, this was done in Mexico, I believe, and they included 55 Hispanic lupus patients. And the clinical and immunological features were evaluated periodically. These were just 55 Hispanic lupus patients. And their clinical features were evaluated periodically, and these patients were followed up in a period of 1 year, and they were searched and monitored for the development of infection. So this is how they developed the so-called LIPI, or LIPI, which is the Lupus Erythematosus Infection Predictive Index. It combines clinical as well as immunologic parameters in predicting infections in patients with SLE. So here are some of their, I just put in the significant values that they showed in their paper. Among these 55 patients, 18 of these patients presented 19 infectious events, and 5 of these were severe. Now, for the construction of the index, they were able to identify via logistic regression analysis certain areas which were of significance. We showed signals that these were going to be significant parameters by showing differences from the baseline of these patients and during the time that they developed the infection. So they were able to find statistical significance between baseline and infection, in that the contributors there were anti-Smith antibodies, T helper 2, the levels of T helper 2 cells, the low-density granulocytes, and the low-density granulocytes in terms of numbers as well as percentage, as well as the NET, or neutrophil extracellular traps, by fluorescence intensity. So these were found to be significant from their baseline, wherein they did not have infection, to the time that these same patients, 18 patients, developed some kind of an infection. And if you look at their analysis, so these authors analyzed now further, so what were the variables that seem to contribute to infections? And they showed that by logistic regression, again, the variables associated with infections included the anti-double-stranded DNA antibodies, the absolute numbers, these are the absolute number of low-density granulocytes, T helper 17, as well as the expression of toll-like receptor 2 in the total monocytes. So as I mentioned, they did more elaborate sensitivity analysis. They put in the cutoff points. They made out a tool, a predictive tool by an elaborate analysis, and Then they were able to determine cutoff points, score assignments, sensitivity analysis, according to the relative risk and likelihood ratio of variables included in the LIPI, or Lupus Infection Predictive Index. So in short, they were able to identify, and these were the significant numbers, the cyclophosphamide use. So whether it's yes or no. So you had more cyclophosphamide use in those with infections. You have higher numbers of you have higher numbers of T helper 17 cells, as well as maybe lower numbers of your B cells. Therefore, there were less of the maybe immune response there. They were suppressed here, and in those with infection. So looking at that, and they also included, because this now turned out in their further analysis, in the looking at baseline data, they were able to show that it also eventually included the toll-like receptor 2 intensity, which turned out significant. Even with the univariate, it did not turn out significant. But when you combine it now, so when all these variables were selected initially, thus being able to predict infection based on what they called as the ROC, or receiver operating characteristic curve analysis, they included actually 4 of these elements. These are cyclophosphamide use, absolute number of B cells, and T helper 17 cells, as well as the toll-like receptor in total monocytes. And if you can see here, the LIPI includes this. It's a combination of this, actually. It's a combination of all these factors, which turned out to be significant in those who develop infections, versus the scores were higher, the cutoff scores were rich in those who develop infections versus those who did not, versus the group who did not develop infections. So just to summarize their point here, in that increased numbers of peripheral T helper cells, B lymphocyte lymphopenia, so lower numbers of B cells, and lower toll-like receptor 2 expression, as well as cyclophosphamide use, were the major risk factors for the development of infection. And this data suggests that the combination of cyclophosphamide use with compound measurement of B cells, T helper 17 cells, and toll-like receptor 2 expression in monocytes is a useful index, or useful as a prediction, infection predictive index in our lupus patients. Now, I'd like to put in a little, these are now my words, and this should be, I think, again, this should be part of our research agenda in our part of the world. How to validate this? Can we validate this? Can we use this now? Not just by clinical elements, not just by steroid use, but also by looking at now your immunologic factors, or as they would appear in the laboratory. Now, let's go now into the hot item of lupus and coronavirus. And we do know that coronavirus, in this time of pandemic, we have learned more and more about the biphasic pattern that we see among our patients with lupus, which is why we have asymptomatic COVID-19 to mild to moderate, and then to severe, wherein they have the cytokine storm. So the biphasic pattern actually includes an early viral response, of course, that's your innate immunity, and then moves on into, as they reach into critical, severe, and critical illness, you have more of the inflammatory response. So why am I showing this? It's because the response seems to be very similar. The response to coronavirus infection seems to be very similar to what we have in many, many viral infections, wherein you can have the proper or appropriate response, wherein you can have viral infections regardless of the cause. You can have the consequences, but then you stimulate now your immune response to it. You have a protective immune response, and you have survival and recovery. On the other hand, in cases of severe COVID infection, something goes wrong somewhere, wherein they have a dysregulated immune response. You have the viral infection, and then you have here, again, central to this is now interferon, similar to this, but you have more interferons. And in addition to that, you have more cytokines. And these are the pro-inflammatory response with your cytokines and your interferon. And the consequences would now lead to increased epithelial and endothelial damage and apoptosis, increased vascular leakage, and Therefore, you have now an inappropriate inflammation. So it's no longer directed versus your virus per se, but you now mount an something like an auto antibody response. So something that goes against your own system. It's an over response. So it's a hyper response. You now have also, in addition to that, you have poor viral clearance because it's an inappropriate response. You have ARDS, and the outcome can potentially lead to death. So this is an interesting study by Bastard and al. Et al. In the UK, I believe, wherein they looked at the type 1 interferons in patients with life-threatening COVID-19. And they were able to show that the autoantibodies versus type 1 interferons showed that these were 101 out of about 900 or close to 1,000 patients with life-threatening COVID-19. They actually had a lot of autoantibodies. They had a lot of remember it's autoantibodies versus interferon that completely blocked signaling by interferon and interfered with their function. So towards the time of life-threatening lupus, when you have now more of these autoantibodies, then the type 1 interferons, which are supposed to get rid of your virus, are already dysfunctional. They cannot anymore function because of the autoantibodies that are being produced versus your type 1 interferons. And that leads on into why these are now form the life-threatening, in addition to proliferation of the virus, because you have useless type 1 interferons, which are blocked. You also have the autoantibody response. And you can see here that in life-threatening COVID, in their study, in a multiplex analysis, they compared life-threatening COVID-19 versus asymptomatic but nonetheless infected versus healthy controls. One can see that the autoantibodies against type 1 interferons were definitely higher in life-threatening COVID, whereas in the asymptomatic that was comparable to healthy controls, they did not have the autoantibodies. So that explains why you have a hyperinflammatory response, because of the cytokine production, the high interferons, which were no longer playing their usual role versus the viruses, but they were producing now an autoimmune response. And this was also shown. They did also further analysis in that these were more common, the presence of life-threatening COVID-19, in the presence of life-threatening COVID-19 among these patients. There were more males who had the type 1 interferon autoantibodies, and comparing, there was not much of a difference. So you would have equal distribution of these autoantibodies between those who were younger and the older. So this is a nice Venn diagram, and it displays the differences and similarities between incidence, clinical findings, and immune responses in SLE and COVID-19. So perhaps outside of this, you would have asymptomatic, but we're now referring to the more severe COVID-19, wherein you have more of the useless inflammatory response. One can see that some of the similarities and differences, whereas lupus is more in women. You have higher mortality in men in COVID-19 and in anti-double-stranded DNA autoantibodies. But here you have anti-SARS-CoV-2 antibodies, and you also have type 1 interferon response, which can range from asymptomatic, but we have autoantibodies to type 1 interferon towards the severe part of the COVID-19 or life-threatening illness. So timing, timing is crucial when we talk about type 1 interferon response in patients with COVID-19. So you have also ARDS here, which is typical of life-threatening COVID-19 infection or severe COVID-19 infection. Here we know also that there is a sharing of your type 1 interferon which can be pathogenic in the autoimmune process, whereas the antibodies versus interferon can be the ones that can be, and these are autoantibodies, can be the ones that can be pathogenic in patients with severe COVID infection. And shared here will be, of course, in lupus, you have it's more common among Blacks, Hispanics, I would say Asians also. Lymphopenia is shared between lupus and COVID-19. Cytokine storm can occur in lupus, as well as tissue damage can occur in both lupus and COVID-19. So it's an interesting, and you can speculate about many other things that occur in here on what else is shared between lupus, severe lupus, and severe COVID likewise. So it almost looks like a lupus flare. And this is an interesting study. This was done by Emory. This was in Emory, that's in UK. This is in severe cases of COVID-19. The Emory researchers have been observing an exuberant. So these exuberant CD19 B cells. So they have higher numbers of activation of your immune cells, particularly B cells, with higher numbers of antibody secreting cells. So antibody secreting cells are actually your ASC in here. And you can see that these are the ICU patients, these are the outpatients, usually asymptomatic COVID, and these are the healthy controls, so healthy population. So one can see that there are higher levels of antibody secreting cells, definitely, and that is with your B cells, higher numbers of B cells that are activated. So it's a prolific B cell, very, very similar to what we see with lupus, very similar to what we see. And that's the reason why we have now these B cell directed therapies in lupus. Now, in the future, you can always look about what else can you do. Can you probably do the same thing because of this shared pathomechanism between severe COVID and lupus flare? Oh, it would be interesting to find out what they would eventually, what the scientists would eventually look at into. Can you now share, because of these shared pathomechanisms, can you share medications, targeted medications? So just allow me to share with you some of our cases with infections among our patients. This is a 33-year-old female lupus and soft tissue abscess. I said soft tissue abscesses are common among our patients. And this was a MRSA infection. So treated as MRSA, fairly straightforward. At that time, she had mild lupus activity also. Now, this is the same patient 5 years later. So just this week or last week, maintained on hydroxychloroquine, disease was quiescent, and came in with sore throat, fever, cough, colds, and nausea. O2 sat and chest x-ray were thankfully normal in these patients. It turned out to be SARS-CoV-2 positive and came up with these curious rashes, which again, I'm now stimulating, I am prodding my fellows, have more studies on these patients, because we have to understand why they have these curious rashes, which we think it's not due to lupus, but may be related to the COVID infection. And this is in a cohort of patients with lupus who developed COVID-19 infection. Another patient, this is severe COVID-19 infection, and this is a patient to a 24-year-old female with lupus nephritis who's on MMF and CNI, hydroxychloroquine, and prednisone. So the way we treat our lupus nephritis patient. Developed disseminated TB. So look at that, and that will be discussed further by Lani here on the disseminated TB in the lungs, liver, lymph nodes, multi-drug at that, resistant, so multi-drug resistant. So she was taking all these medications the past 10 months, and MMF, CNI were discontinued. Thankfully also her lupus nephritis was not acting up. But we had to discontinue that because she was already taking a lot of medications with potential drug-drug interactions. Hydroxychloroquine was discontinued because of prolonged QT and heart failure that developed in this patient. So on the month 10 of anti-TB, she had fever, cough, dyspnea, disorientation, O2 desaturation, and she turned out to be SARS-CoV-2 positive. So here we can see new lung infiltrates and new peripheral ground glass opacities, a new onset. She was placed on these medications, including high flow oxygen, remdesivir, meropenem, baricitinib, dexamethasone, and the anti-TB medications were temporarily discontinued, withheld. And she was discharged improved, happily discharged improved, and anti-TB was resumed in her and completed for 12 months. And I actually pushed my fellows to, with the help of Leonid, to come up with, can you just look at our experience in the last 1 year and 3 months on what would be, because we were now doing teleconsultation, and patients were reporting to us, and every time they would have a COVID infection, they would report to us. So this is, many of these were by virtual, most of these, as a matter of fact, were by virtual consultations. And this is, I'd like to share with you, these are still crude numbers. We just had to rush this for this particular presentation this morning. And I'd like to share this with you. Manuscript is now still in publication, still due for being written for publication, and we're just refining the statistics here. So in about 380 patients whom we saw on teleconsultation, on virtual consultation, 33 of them reported at one point or another the occurrence of or that they were COVID-19 positive by swab or RT-PCR. So here are, this is just an outline of the 33 patients. So just to show you, give you an idea of their medications. So these are the medications that they were taking at the time that they had a COVID infection. So you have methotrexate, mycophenolate, mofetil, azathioprine, hydroxychloroquine in 82%. And prednisone those who were taking more than 10%, 10 milligrams per day were only 15%. Most of them were on low dose prednisone. And the severity of COVID-19 infection, if you will look at this, severe infection was the one I showed you earlier, but there was one patient who could not come to the hospital for one reason or another, and this patient died due to, so we had one mortality due to severe sepsis and kidney failure. So, but you can see that majority were mild COVID-19. And I'd like just like to point out, so I just pick out this particular graph among the three graphs that I shared earlier. I picked this out because this was a really interesting, challenging case as we discussed this case. This is a 30-year-old female lupus. And in addition to that, you could see that she was pregnant at the time that she had the infection. And not only that, she had a very, very bad infection to start off with. So this is in July 2020, last year, that was at the height of the first wave of the pandemic. This 29-year-old female who had lupus for the past 10 years had active cutaneous lesions. So she presented in the hospital because of febrile neutropenia. ANC was only 42. At the same time, she had pregnancy at 28 weeks, and she did not have any follow-up before that. No prenatal, again, because of the lockdown, the pandemic, ongoing pandemic. So this is how she presented at the hospital. She had pseudomonas sepsis that was borne out by blood cultures. She had HSV, orofacial with cellulitis, and oropharyngeal candidiasis as well. And those are some of the pictures. So on day 2 of admission, she was pregnant. She went into premature labor, underwent emergency cesarean, and gave rise to a live baby boy, unfortunately, who eventually succumbed. 2 days after cesarean, the worsening dyspnea, O2 desat, increased lung infiltrates, respiratory failure, and she turned out to have SARS-CoV-2 pneumonia. And the antibiotics, steroids, antibiotics were given, steroids, high flow, and went into intubation. Now, thankfully, at the rest of the hospital day stay, she had progressive improvement and discharge on day 28. Unfortunately, the baby succumbed to neonatal sepsis, but the baby was SARS-CoV-2 negative. So it's an interesting case, and I'm sure you have many more cases that you can share as we will have, if we will have the opportunity to that. Because every patient will always teach you something new. So this was a very challenging case. Now, thankfully, she was well on this. And the other day, she actually went in, and you see, here's another issue that we're having among our patients with lupus and in this time of the pandemic. The other day, yes, and that was September 9th, she had a teleconsult, said, I'm having dry skin. And then on assessment, just by teleconsult, she had gave in her laboratories. She just had a rash and then low C3. Prednisone was kept at 5 milligrams. She was able, her rashes had actually improved, as she showed us. And she reports that she completed 2 doses of AstraZeneca vaccine and inquires now and said, I am, my company is offering me a booster. Should I sign up for a booster? I didn't give her a straight answer for that, but I would like to pose that question to you, and probably we can even have a poll if we have an opportunity, and say, what do you think? With the information that's coming in 24 hours a day regarding lupus, regarding immunizations, regarding COVID-19, I'm sure you'll find yourself in some kind of some kind of a mesh of information out there which is developing and among this, and compound that more in our group of lupus patients. So for now, we can just come up with this guidance statement that considerations related to COVID-19 vaccination in rheumatic musculoskeletal diseases and autoimmune inflammatory rheumatic diseases. Let me just read out to you that the level of task force consensus was strong to moderate in the following statements. That the rheumatology healthcare provider is responsible for engaging the patient in a discussion. So it has to be discussed with your patient to assess COVID-19 vaccination status. So that's important, that they should get vaccinated regardless, and engage in a shared decision-making process to discuss receiving the COVID-19 vaccine. Based on the risk for COVID-19, these patients should be prioritized for vaccination before the non-prioritized general population because they are at higher risk, and the expected response to COVID-19 vaccination for many autoimmune diseases, patients on systemic immunomodulatory therapies are likely to be blunted. So that has to be explained to the patient that despite the fact that they have had the immunization, they still have to follow safety protocols because it is blunted, their response to the vaccine is blunted, and even the duration compared to the general population. So those are some of which are statements that have reached at least a moderate level of consensus in the task force for this. So in summary, I have gone through infectious agents as playing a role, particularly viruses, playing an important role in the development of SLE, infections significantly contributing to morbidity and mortality in SLE wherever you are. So that seems to be one that is fairly established. The most common infections are bacteria, pneumonia, UTI, and soft tissue infections. Lupus patients are at higher risk for serious infections, pneumonia, herpes zoster, and tuberculosis. And glucocorticoids, especially glucocorticoids in high doses and cyclophosphamide, confer the strongest risk for infections in lupus. Hydroxychloroquine may be protective, and a lupus infection predictive index has just been developed, which combines clinical and immunologic parameters, which may serve applicability in the future and may be considered for research agenda in our part of the world. And lupus and COVID-19 shared type 1 interferon and other pro-inflammatory cytokine pathways play a role. And the role of B cells have been expounded by the Emory group in lupus and severe COVID, which share the same even clinical characteristics, and as well as B cell characteristics. And then we have a single center. I shared with you preliminarily the single center experience of COVID-19 infection among our Filipino patients, showing that majority have mild infection with a high overall recovery rate. And considerations should always be placed on hand on COVID-19 vaccination or immunization in patients with autoimmune inflammatory rheumatic diseases. Thank you very much for, again, the collaboration, the partnership, and the friendship that we've had through